We're gonna finish MSK with a talk on the skin. Now, the skin is the biggest organ you have. Covers your body, does a lot of things. And the skin is made up of your dermis. And above the dermis, we call that the epidermis. And there's something below the dermis, we call it the hypodermis, but that's not really part of the skin, that's just kind of fat. So I just write hypodermis. Now your dermis has a lot of things going on for it. Your dermis is where your blood is. Your blood vessels, your nerves, your glands. Your dermis is mostly acellular, made up of type 1 collagen, and really supports and supplies your epidermis, because this is where all your blood supply is. Let's just talk about the glands for a second. So glands, you can have things like sebaceous glands. Sebaceous glands. You have your hair unit, so just a hair coming out of the pore, and a muscle called the pili muscle that erects it and makes it nice and straight. And your sebaceous gland basically gives out oil and moisturizer for your hair. So I'll just write moisturizer. Also for your skin. You have, of course, your sweat glands. Your sweat glands, there's two types of them. You have apocrine sweat glands, and the apocrine sweat glands are in your sex organs, your breast and your areola, your axilla, and they really start to secrete sweat during puberty. They are hormone sensitive, so they secrete extra amount of sweat during puberty. But we know that's not the only type of sweat glands you have. You can have your regular eccrine glands, and these are just everything else. And these are stimulated by cholinergic, aka sympathetic activity. And so if you have increased sympathetic activity, you're heart beating, sweating, all that stuff. And if you block it, if you have some sort of anticholinergic, if you give a patient an anticholinergic drug, what do you think will happen? Well, their skin will stop sweating, they'll get really dry skin. So anticholinergic, antichol equals dryness. This is to talk about your glands. That's your dermis. Let's talk about your epidermis. Your epidermis is made out of stratified squamous epithelium. And you can actually cut your epidermis into multiple layers. All right, so let's do that. We'll start with the bottom layer, the basal layer, the basale layer, B-A-S-A-L-E. This is where all your stem cells are. So it makes practically almost all the cells that we associate with the epidermis. So it makes your skin cells, aka your keratinocytes. And they call them keratinocytes because they pick up keratin, and then they'll die, and then that keratin will just deposit on the top of your skin, and the top of your skin is basically like keratin debris. So we call them keratinocytes. All right, pick up. I'll just write keratin. They also have lamellar bodies inside the keratinocytes, and these create things that make your skin a little bit more waterproof. And so these keratinocytes will start to migrate from the bottom, your bottom basal layer up, because that's where it has to deposit that keratin. Yeah. Some other cells you can find in here, you can have your Merkel cells. Merkel cells are these neuroendocrine cells that help with fine touch. So I'll write fine touch. Fine touch. You have your dendritic cells. Hopefully you know what dendritic cells are. These are your macrophages in your skin, and so they're antigen presenting cells. They pick up baddies, deliver them to T cells and B cells, and help our immune system do its thing. These are your dendritic cells. And then you have your melanocytes. We're going to talk about melanocytes in more detail later, but these are all the cells in your basal layer, basales. Next layer up, you have the spinosum layer. Spinosum. And they call it spinosum because you have these spiny projections, and so they call it spinosum. Spinosum for spine. That's what it looks like on histo. And there's not really much to talk about this. The next layer is going to be your granulosum. Let me draw it in a black marker. The granulosum is much darker. It's much darker because your keratinocytes, as it's moving up, when it gets to this layer, it has these really dark granules that help it bind keratin. So, all right, granulosum, bind keratin. And your keratinocytes will start to die and lose their nuclei at this area. The next layer is your lucidum. Lucidum, this kind of white ghost-like looking layer. Lucidum actually means clear. So your lucidum is only found in thick skin, like your palms and your soles. And the dead keratinocytes are going to start to flatten out. And then finally, your last layer is your corneum. Your corneum is basically the outside layer, and it's those dead keratinocytes with the keratin debris. So I just write keratin, and there's a layer that if you kind of brush your skin will shed off. Yeah, so microscopically you can't see it, but I'm shedding a lot of keratin off. So that is your layers of your epidermis. Now before we move on, I just want to go over some more definitions. So when we're talking about pathology, you know what I'm talking about. There's something called hyperkeratosis. Judging by the name, there's increased keratin. So this is an increase in your corneum layer. So certain pathologies cause it. So when I say hyperkeratosis, it just means increase in your corneum layer. Parakeratosis, okay. I get the keratosis part. This is increased corneum plus the retention of your nuclei. We said midway through, your keratinocytes will gather keratin, but then they'll die to release that keratin, and when they die, they'll kind of lose their nuclei. So here, for some reason, your keratinocytes don't lose their nuclei. They keep that nuclei all the way up to the corneum. So it's increased corneum and the retention of nuclei. You can have hypergranulosis, making things too easy for us. Hypergranulosis, increased granulosum layer. All right, increased granulosum. You can have spongiosis. Spongiosis. This is just fluid in the epidermis. Fluid in epidermis. I just remember it as like a sponge full of fluid. Acantholysis. Lysis means to break apart. Acanth actually means spine. So this is the breaking apart of your epidermis, usually at the spinosum layer. Another picture, a great picture will be in my notes, so check that out. So basically, comes apart. And lastly, acanthosis. This is increase of your spinosum layer. Increased spinosum. Hopefully that just clears up some terminology. And there's commonly tested in both medical and STEP. So make sure you know what the definitions are. Usually you can figure it out if you know kind of the meaning of the word. You can usually figure out what you're trying to say. All right, so that's your epidermis, that's your dermis. We talked about a cell, and I said I would talk about it more in detail, and that'd be your melanocytes. Let's talk about melanocytes. Your melanocytes are these neurocrest cells that go to your skin. So, all right, neurocrest cells. And they do a special thing. They take tyrosine, which is an amino acid, take tyrosine and turn it into melanin, this pigmented thing. And that melanin is what gives us our skin pigment. And so it turns tyrosine to melanin. And it packages that melanin into melanosomes, this organelle that holds melanin. And then it can pass that melanosome onto other things like keratinocytes. And through this kind of pathway, this mechanism, we get our melanin, our pigmented skin. Now, what controls this melanogenesis, the making of melanin? Well, UV radiation does. That's a no-brainer. You go out in the sun, you're going to get darker, you're going to increase this pathway. Something else, at a more kind of central and more basal layer, if you don't go out in the sun, you don't suddenly become ghost white. You still have that basal level of melanin, right? And this is due to a hormone we produce called melanocyte stimulating hormone. And this hormone stimulates your melanocytes. Now there's something you should know. Melanocyte stimulating hormone and ACTH both come from a precursor, POMC. So anything that increases ACTH will increase melanocyte stimulating hormone. So if you have your adrenals are shot and you're not making corticosteroids, your brain's gonna say, oh no, I need to rev this up somehow, and it'll start creating a ton of ACTH. And when it creates all the ACTH, you're gonna inevitably increase more MSH. So like in Addison's, you'll have people with renal insufficiency that have pigmented buccal mucosa or pigmented skin. And now you know why. So they both come from the same precursor, and you can't have really one without the other. All right? So that's how you produce your melanin. Now there are some disorders when it comes to melanocytes. You have decreased melanocytes. You'll see this in vitiligo. And this is when there's an autoimmune antibody attack against your melanocytes, and it destroys it. So you get these spots of basically no melanocytes, so these white spots, and they can coalesce and increase in size. In light-skinned people, it might be more difficult to see, so a good thing you can do is under UV light, aka woods light, it'll fluoresce. So alright, fluoresce under UV light. Also associated with skin cell radiation and damage, so like sunlight. Back where I used to work, there used to be a lot of people that worked out in the fields, and they would all come in and I realized so many people had vitiligo because that was the only part that was exposed. Basically their hands, everything else was covered, and all their hands had it. And so now I realize why. So it's also associated with UV radiation. Okay? You have increased melanocytes. How do you think that will present with? It will be hyperpigmentation, so darkening. It's going to be things like solar, lentigo. They're just old age spots. A lot of old people just have these darkened spots, and that's just UV light causing melanin to increase production. So completely benign, just very, very normal, very, very common. Solar, lentigo. You can have nevus, aka a mole. So that's just a bunch of melanocytes grouped together. Because you have all these increased melanocytes, you can actually have an increased chance for melanocyte cancer or melanoma. We're going to talk about that later, but back to just the common mole. You can have different types of moles. You can have junctional. This is one that's in between your epidermis and your dermis, and these are usually flat. So I'll just write macule. You can have intradermal, which is inside your dermis. And these are commonly more seen in adults, and these are raised, so papule. And then you can have compound, which is the best of both worlds, basically. Has characteristics of both, kind of in between macule and papule, and seen more in children. That's melanocytes. How about melanin? Well, you can have decreased melanin production. And decreased melanin, you'll see it in albinism, aka an albino. So, and the mechanism behind albinism is vast. There's a whole bunch of different things. Some of them can be like neural crest failure to migrate, neural crest migration, and if your neural crest cells don't migrate, then your melanocytes will migrate and won't make melanin. If you have something wrong with your tyrosine activity or transport, if you don't have tyrosine, you can't make melanin. So all these things cause decrease in melanin. Sometimes they won't just say this person's albino. That's a little too easy. They might just say light skin and silvery hair. That's just like a code name for albino. So light skin, silver hair. Or they might say fair skin, very fair skin, silver hair. And this increases your risk for cancer. You're not making that protective melanin. How about increased melanin? What the heck can cause increased melanin? Well, freckles is one. Freckles is just increased melanin. So they go out into the sun, sunlight hits, increased melanin to get darker freckles. They leave, don't produce that much melanin, then their freckles kind of go away. So freckles is one. Melasma. Melasma, it seems that estrogen and progesterone, or EMP, stimulates the production of melanin. And so in people that are taking OCPs or people that are pregnant and they have more of these levels, they get this hyperpigmentation usually around their face. So I write OCP, pregnancy. completely normal, if they take away the drug or if they deliver the baby and they're no longer pregnant, that level drops and the hyperpigmentation goes away. So it's more cosmetic than anything. If someone's worried about it, just kind of reassure that it'll go away. If they're pregnant or if they want to switch to some different type of birth control, you can do that too. All right, I think that's enough about melanocytes and melanin production. We talked about our layers of our epidermis, these kind of cells that are just stacked on top of each other. How do these cells stay together? Well, they need a bridge, basically, to kind of link them all together. And that bridge we call cell junctions. Cell junctions. So if you have one cell here and one cell here, you gotta link them together, make sure they stay nice and close, otherwise it'll just float everywhere. My skin will just be floating out in the sky. So we gotta keep them nice and close. And there are connections that go side to side, connect side to side. Shout out to Ariana. And there are a lot of these. You can have tight junction, and judging by the name, forms a very, very tight seal. And the purpose of this tight seal is to kind of stop any bad things from moving from cell to cell. So if you have like some sort of chemical going in one cell, you don't want to spread to your other cells. So the fancy way to call this is zonula occluded. Basically a zone of occlusion. So if anyone calls it that, you can just kind of cringe, but that just means zone of occlusion or a tight junction. And proteins that make up this tight junction include things like occludin, what a fitting name, and cloudin, which means to close. So they're really emphasizing it being closed. So that's your tight junction. You can also have things like adherent junction. This again helps link the two cells together. And adherent junctions, if you basically have this giant block of protein, then adherent junctions will link these proteins with a transmembrane protein. Transmembrane meaning cross membrane, so it'll link it with a transmembrane protein. Okay, it forms like this belt. So we can call the adherence junction zona adherens, basically again zone of adherence, or belt desmosome. Now this giant block of protein is often your actin filaments, and the transmembrane protein that kind of links it together is going to be your cadherins. Cadherins gets its name because it's a calcium-dependent adherence molecule. Some physio fact: if you lose cadherins, especially E-cadherin, a subtype of cadherin, then your cells no longer stick together, and so they kind of can move apart. And it's important because in cancer, if you lose E-cadherin, then your cells can move apart, and it's easier to metastasize. So that's just a physio fact. It's in my notes if you want to make sure you got that written down. So cadherins, that's your adherence junction. There's another one, kind of like an imitator of that, called your desmosomes. And it's very similar to your adherence junction, but it's more localized. It's not as big as this. It's more localized, like a spot weld kind of. So instead of calling it zona adherens, we call it macula adherens. Kind of like macula of the skin, just a small spot. And instead of calling it belt desmosome, we call it spot desmosome. Really just emphasize the fact that it's kind of like a spot weld, a very localized connection. But it shares the same characteristics. They'll link a little protein on both sides with a transmembrane protein. And that little protein that it's trying to link is going to be your cytokeratin, aka your intermediate filament. And the transmembrane protein is going to be your desmoplakin. All right, one more side-to-side linkage. This is going to be your gap junction. Your gap junctions are your gap junctions. They allow communication between a cell, so electrolytes to flow through, and it's important for cells like your heart. If you need to depolarize a lot of cells at the same time, allowing that communication allows them to work together. So gap junctions allow communication. Gap, communicate. How does it do that? It has proteins called connection. It's a pretty fancy name. So these proteins make channels, and that channel allows them to talk to each other. So these are all side-to-side connections. How about top to bottom? How about up and down? We have one, a very special one called hemidesmosome. This links top to bottom. It's especially important of linking the cell to the basement membrane, keeping it still to the floor. It does that because these cells have keratin, and it takes that keratin and links it to the basement membrane proteins. Proteins like collagen, laminin. All right, so hemidesmosomes link your cells to bottom or the basement membrane. As your skin, hopefully that just lays down some foundation, and I hope you enjoyed the video. Thanks.